Good morning, everyone, and welcome to this meeting of the Audit and Performance Committee of the Perth and Kinross Integration Joint Board. If I could pass over first to Committee Services, who will outline the apologies that we have for this meeting, any substitutions and those in attendance. Thank you.
Okay, thanks, Chair. We've got apologies this morning from Ronnie Erskine, who is being substituted this morning by Donald McPherson, and we have apologies from Bernie Campbell, who is being substituted by Maureen Summers. Okay,
thank you. And we also have, I think, in attendance the Chair of the IGB in an observer capacity, and you're more than welcome also to ask any questions that you want during the course of this meeting. Just to welcome Mr. McPherson to this meeting, and thank you for joining us today in Mr. Erskine's absence. We do have quite a lengthy agenda today, so if I could ask everyone to keep their questions and answers concise, but we'll try to get in as many as we possibly can. And also, as before, if possible, if you could use the chat function to indicate if you wish to speak. Okay, I'll first ask members if they have any declarations of interest in accordance with the Integration Joint Board Code of Conduct. I'll take silence to indicate that there are none. So we'll then move on to item 3, which is the minute of the previous meeting, and item 3.1, which is the minute of the meeting that we had on the 15th of February. Are members content? Oh, I think we're having a bit of feedback. If we could just check that everyone is on mute if they're not speaking, if possible. Can I just check that members are content with the minute and that that is a true and accurate record of that meeting in February? I'll take silence to mean that we are in agreement. Okay, then we'll move on to item 3.2, which is the action point update. And I'll perhaps ask the Chief Financial Officer very briefly just to give any points that she wanted to raise in relation to the action point update.
Thank you, Chair. I'm actually going to pass over to my Chief Officer, who's going to outline the actions.
Okay, Chief Officer.
Thank you, Chair. Yes, if I could just draw members' attention to the action point update, which is on page 11 of my papers and hopefully of yours. Reference 41 pertains to the management and oversight of sickness absence across the partnership. We have been in touch with the HR departments of NHS Tayside and Perth and Kinross Council in order to progress this. Part of the challenge inevitably is that the information that's recorded in relation to absence pertaining either to COVID, to self-isolation or to other reasons for absence is recorded in different ways by the two statutory partner organisations. So we're seeking to reconcile that. However, it would probably be important that I reassured the committee that operational managers within the service are fully adopting and applying the managing attendance policies of the respective organisations, engaging with staff who are off sick through either short-term or longer-term absence, and taking the necessary actions to try to secure their return to work at the earliest opportunity possible. However, the report that's requested for the Audit and Performance Committee, we will continue to produce, continue to develop and anticipate that we will provide that towards the end of the summer. Hopefully that will be satisfactory to members of the committee.
Okay, thank you, Chief Officer. Can I ask members if they have any questions on the action points update or any comments that they wanted to make? If they could indicate if they want to speak.
Can I ask a question?
Oh, yep.
I just wondered if someone has been in touch with someone that has had COVID, but they test positive, but they have no symptoms, and they're working from home. Are they automatically counted as being sick, or can they still work from home if they have no symptoms?
Yeah, some people will be available to work from home during a period of self-isolation, either because they're positive or because they have been a close contact. But obviously there are a number of duties, tasks and responsibilities that require people to come into the workplace. So that, I suppose, Maureen, illustrates one of the challenges in relation to how these matters are recorded and reported slightly differently by the NHS and by the council.
Because that will affect the figures then, you know, so I just wondered how you recorded it.
Yeah, so what we'll have to do is ensure that we're providing that level of detail in the figures, because the other consideration that increasingly we're having to take into account is that a number of contacts of people will have to self-isolate. That's a reflection of the increased numbers of community infection rates. But equally, that reflects some of the challenges that we're experiencing with an increase in the number of school-aged children who are having to self-isolate, and sometimes their parents will perhaps have to take care or leave or time off work in order to look after them. So we will ensure that we're providing information that enables some both comparisons between the two statutory partners, but an aggregated position in relation to the sickness absences that the Health and Social Care Partnership is experiencing, either as a result of COVID or as a result of self-isolation, or indeed in terms of other more routine health absences.
Okay, thank you, Chief Officer, for that response. And just to add, if there are no further questions or comments, that's welcome to see the risk workshop, risk appetite workshop is in place for the 25th of August. I know that's something that a number of members were quite keen to see following discussion at the previous audit and performance meeting. So with that, we'll move on to the next section of the agenda, performance, and item 4.1, which is the 2020-2021 financial position. And I'll ask the Chief Financial Officer to introduce this report.
Thank you, Chair, and good morning, members. We recognised that this was a very busy agenda for the meeting this morning, but we wanted to take some time to provide a short presentation which ties together a number of the papers that you'll be asked to consider today: the year-end financial outturn report, the draft annual accounts, which are before you today for approval, and a brief forward look linking to the strategic risk register, which is also provided for you today. Just before moving on to the presentation, can I take the opportunity to welcome Mark Grant, who's with us today. Mark is Donna Mitchell's deputy, and Donna unfortunately can't be with us today due to unforeseen family circumstances. I'd just like to take the opportunity to thank Donna, who's been an enormous support in bringing forward the annual accounts and the ongoing financial monitoring that is considered by the Audit and Performance Committee and the IGB. And thank you to Mark for being with us today to answer any very technical questions. So looking back, first of all, on the 31st of March 2020, the IGB set a budget for the year ahead expecting to be overspent by 1.1 million. By then, however, COVID-19 was upon us, and the IGB noted the significant uncertainty for services and for expenditure levels. We now know and can see very clearly from the 2021 outturn finance report that the impact on expenditure levels has been very significant. A £3.9 million underspend on the operational position, alongside £8.293 million of expenditure on our direct response to the pandemic, met in full by additional Scottish Government income. Now, I'm pleased that Zoe Robertson and Evelyn Devine will shortly give you a brief overview of the key drivers of the operational overspend, which is the £3.887 million. Both the operational overspend and wider movement in reserve will lead us to an overall surplus in the annual accounts of 12.741 million. Now, as I say, that's made up of the operational underspend of 3.887 million, excess funding that we've received from the Scottish Government for our COVID response of 4.547 million that we're being asked to carry forward in our reserves to meet COVID expenditure next year. £1.4 million of money received from NHS Tayside in 2021 to be carried forward to balance our financial plan for 21-22, and members will be aware of the discussions around that bridging finance at previous IJB meetings. And 2.907 million of additional Scottish Government allocations that we've received in the final quarter that meet commitments in future years that the Scottish Government have asked us to carry forward from 2021 into 21-22. So you'll see later on in the annual accounts an overall surplus of 12.741 million being reported. I'm going to hand over at this stage to Zoe first of all, and then to Evelyn, just to explain a wee bit more about the underlying operational surplus and how it relates to social care first and then to our health services. But I'll ask Audrey just to move on to the next slide and pass over to Zoe, and we've got health first, to Evelyn first.
Good morning, everyone. So I am just here to sort of give you a sense of the health variance in relation to our staff costs. You can see there, in general, the 512 is made up of basically national recruitment challenges, slippage in recruitment timescales, and inability to recruit during the COVID period, where staff and the workforce really didn't want to move around a lot. So that's just pretty straightforward in terms of where we're at with our underspends. In relation to our investment monies, there's been some slippage in the respiratory team because, again, we had about 3 rounds of recruitment to achieve recruitment to the team, which is obviously now in place. So that investment spend is really all accounted for. In relation to intermediate care beds, this was just a development opportunity that we weren't able to take forward through the COVID period, and actually we didn't really have the demand for the intermediate care beds, so that was something we put on hold in order to really look now at where we need to spend our money coming out of COVID and into recovery, and we're seeing different challenges in different places, so we're really needing to have a proper think now about where that investment needs to go, whether that's into community teams as opposed to beds or vice versa. So that's really, Jane, all I want to say at this stage.
Sorry, Evelyn, I was on mute. If we could pass over to Zoe for the social care position. Thanks, Zoe.
Hello, yes. As you can see, there are a variety of areas within social care where we have had reduced spend, but by way of reassurance with regards that adult social work and social care services continue to provide support to all service user groups during the pandemic. But face-to-face provision had to be scaled back in line with Scottish Government guidance. This was always done on the basis of risk assessment, of course. We had to work differently, and as such, the delivery models were altered and prioritised as we looked at essential provision. So staff provided support virtually wherever possible. Hard to reach clients were provided with mobile phones to enable them to stay in contact. Face-to-face support has always been available if the person was deemed as critical or at any substantial risk. There have been increases in particular areas of service delivery, such as carer support, mental health issues, and support with alcohol-related issues. But equally so, we've experienced a reduction in numbers of people moving to care homes and numbers of people going to care homes for respite. This is really quite a significant reduction in demand for care home placements, but we do believe that this is likely to be temporary, and demand is expected to increase as confidence in the sector grows again. The number of people being supported by our internal and care at home services decreased significantly at the start of the pandemic, but we're now experiencing heightened demand, and those that are now being referred are often more dependent than those referred pre-pandemic. We think the initial decrease was driven by several factors, including people avoiding coming forward during the height of the pandemic. People who were previously unable to help out in a caring role were now available due to changes in their employment status, furlough, etc. People felt uneasy with regards infection prevention control and felt that limiting the number of people coming into their home made them safer. To address some of these pressures, we've increased our internal care at home provision, we've funded enhanced carer posts within our external care at home provision, and we've provided targeted funding for our third sector partners, specifically in relation to mental health and carer support. Day centres had to close during the height of the pandemic due to social distancing guidance and regulations, but they've now been able to reopen with reduced numbers. However, during the pandemic, virtual support classes were offered to all daycare, day opportunity clients, and outreach support was put in place. The staffing underspend is driven by vacancies that we weren't able to fill during the pandemic. We retasked staff to be able to absorb some of those pressures that we were experiencing. We are still experiencing ongoing staffing pressures due to vacancies and recruitment challenges, COVID and non-COVID absences. Recruitment within health and social care pre-pandemic was challenging, and this hasn't changed, and in some respects the pandemic has made that situation slightly more difficult again. We're seeking to advance our remobilisation plan, although the increased case numbers in community services will require us to monitor the situation and to refine our responses accordingly. As we've done throughout the pandemic, we've had to work in a very dynamic manner and in response to any increase in cases within our community settings. Jane.
Thank you very much, Zoe. Thank you. If I could ask Audrey to move on to the next slide. I thought it would be useful to provide Audit and Performance Committee members with the national context and where we sit, you know, in relative to the rest of Scotland. So 29 IJBs across Scotland are reporting underspend between 1 million and 55 million. And our 12.7 million sits very much within that scale. And what we've had fed back is that the Scotland-wide underspends are significantly driven by the Q4 Scottish Government allocations being passed out in 2021 for spend in future years. What we're also being advised of is that operational underspends across the country are very similar to our own, driven by slippage and investment in new models, driven by temporary reduction in service provision, and driven by these increased recruitment timescales and just the inability to recruit while you know, the COVID pandemic you know, proceeded and staff didn't want to move, and that's been experienced right across the country. Across the country, overall reserves have increased from 139 million to 556 million, but the vast majority of reserves across IGBs are fully earmarked. And that despite those high levels of reserves and that increasing levels of reserves, what we are describing and discussing as CFOs is that recurring financial sustainability is now a significant risk, because refresh plans that try to understand the impact of COVID need to be developed across all HSCPs, and with that comes a level of uncertainty and therefore a level of risk. If I can ask Audrey to go on to the next slide. What we've set out here is the £13.9 million of reserves that is set out in the annual accounts. We can see that is made up significantly of the operational surplus, the 3.9 million that we've just described, the excess COVID funding, the bridging finance from NHS Tayside, and the £4 million of Scottish Government priorities. And what we can see from the slide here is almost all of those reserves are fully ring-fenced, either to balance the financial plan, to match expected COVID expenditure in this financial year, or to deliver against significant Scottish Government priorities, including the ongoing implementation of the GMS contract, mental health Action 15, drug death funding, district nursing funding, complex care funding, a number of new and existing commitments that we've now been passed the money and we're carrying forward to meet these commitments in future years. So yes, we've got significant reserves. However, they are almost all fully ring-fenced. The final point I wanted to make was just linking it to the strategic risk register that is also presented to the IJB for consideration today. Well, the COVID pandemic gives concerns both from a financial resources perspective, particularly in light of the significant Scottish Government commitments, not just to the ones that I've mentioned, but also in respect of the independent review of adult social care, which carries with it significant potential financial costs for the Scottish Government. So alongside our own demographic pressures, alongside our own concerns about the shape and scale of the need for future services, comes concerns about the ability of the Scottish Government, given that wider commitment around independent review of adult social care and a risk around the funds that will be available to meet all of that. The financial risk register continues to highlight financial resources as a very high risk, but there are other high risks there too. The workforce and the availability of workforce is a significant high risk, and the IJB at its meeting at the end of June will consider our one-year workforce plan, and in there are already some significant risks emerging. The risk register also identifies capacity and flow as a significant high risk, and again Gordon will talk to you about the reasons why that has been escalated. And safe working, as we begin to understand the longer term implications of keeping people safe in hospital, is also a risk. So the risks we face and the scale of the challenge we currently face is significant, both in terms of our continued response to the pandemic, which is still ongoing day in, day out, but our commitment to longer term planning will be challenged to the full, given the uncertainty of the landscape. And I have to say, as Chief Finance Officer, delivering a 3-year, a medium term financial plan, as is our commitment, is going to be a significant challenge given the uncertainty that we still face. I hope that's been a useful backward look and forward look for the committee, and that really ties together a number of papers. But at this point, I would probably open up for questions, Chair, in terms of the month 12 outturn report.
Okay, thank you very much for that, Chief Financial Officer. That was very helpful, and thank you also for the presentation. I'll ask if there are any questions either on the presentation or on paper 4.1. Perhaps if there are any questions on non-financial risks, then we can leave them till when we get to the risk register section of the agenda. But if anyone could indicate in the chat if they would like to ask a question. Okay, well, while we're waiting for any questions to come through, I'll ask one.
Can I ask, Chair?
Oh,
sorry,
yes,
sorry.
Mrs. Kilpatrick.
Yeah. I mean, there's obviously a number of areas where we can't recruit or demand's reduced. The can't recruit issue obviously is a difficult one, Jane. And I do sometimes want, because once things hopefully start to normalise again, I think there's maybe an issue about whether we just plough on with what were our previous operational demands and plans, because I see this as an opportunity to do things differently. And I wonder if maybe we need to take a bit of a look. If you think about respiratory care, for example, or you think about elderly people living at home, I'm not sure to what extent your technology-enabled services, how broad that is, but it would seem to me that in the future, the workforce is going to continue to be one of the biggest rate limiting factors. So instead of just trying to employ lots more people in the future and do the things that we're trying to do, would this be an opportunity to stand back and say, if we use technology enabled care, would that mean that we could still provide good and essential services to patients, but necessarily they wouldn't be as manpower intensive? You know, so if you're a respiratory nurse and you're going in and out of people's houses every day, there's always going to be the risk of carrying infection, whatever that infection might be. B, it's time consuming. You've got to travel from place to place, and a whole risk of other things. The human factor is obviously immense in all of that, but if you could monitor people's oxygen saturation and other essential tests like that remotely from home, would that not be a way of getting around some of the manpower issues? So by using a digital approach, using technology-enabled care, which is very sophisticated in a number of areas, not just respiratory, but you know, diabetes and other forms of degenerative disease and chronic disease management, then that might be a way of still providing the care, but doing it with a better use of technology, because we're not terribly invested in technology in the Health and Social Care Partnership, as many Health and Social Care Partnerships. You know, we haven't had the money and we haven't had the strategy, but I just wonder now, Chair, is this the chance to stand back and say, we can't just keep trying to do the same thing and working harder and harder. Maybe we need to do it differently.
Okay, thank you for that question.
A long-winded
question.
That's all
right. I think perhaps the Head of Health might be able to answer some of that.
Yes, Pat, thanks for your question. You're absolutely 100% right. We can't keep continuing to do what we've always done. We do need to think differently, and certainly home monitoring for long-term conditions is high on the agenda for NHS side, but also for the partnership. So I think it's really important that we start to look at that, and the respiratory team would be a good place to start. So yes, we are taking that on board, and I think it's really important that we do. The other thing I think though as well is use of medications for respiratory, and there's lots of different ways to look at that now in terms of what studies that have happened nationally in terms of switching people over to single inhalers rather than having 2 or 3 a day. But so it's that whole switch of medication I think is important as well, so that you know people can control their respiratory better. So I think it's a combination of both potentially that will help us, and you know some sort of technical support to people that they don't have to be visited at home, but they can actually be supported through technology, and we do quite a lot of that already. So yeah, I think your point's well made.
Can I come back, Chairman? What I'd like to see in the financial plan, Jane, is I'd like to see a line that shows a significant amount of money put aside to be invested in advanced technology-enabled care, not just round the margins, a significant amount of money and how it's going to be invested. Now, whether if we're to bring in some specialist consultant advisors to help us to do that, I think and I'd like to see that in the financial plan, Chair, and I think that would be an important aspect, certainly for the future. Thank you.
Thank you, Mrs. Kilpatrick. And now I've got 2 questions, one from Mr. McPherson and one from Councillor Duff. But just before that, I think my question probably follows on quite nicely from Mrs. Kilpatrick's. It was just, you talked, the Head of Health, about some of the things that we'll need to reconsider, such as intermediate care beds, and some of the other things where we have underspent in light of what has happened as part of the pandemic and changing requirements. I'm just wondering how we as a Health and Social Care Partnership and Integration Joint Board plan to go about doing that, because we had a very clear rationale set out for investment in certain areas and disinvestment in other areas, and obviously a potential future area, as Mrs. Kilpatrick has highlighted, is further investment in technology-enabled care. But I'm just wondering, do we have an idea of how we would go about that exercise, what the timescales would be, and then also what the Integration Joint Board's role would be in giving strategic direction and oversight to that? Now, I see that the Chief Officer wants to come in, so I'll bring him in first.
Thank you, Chair. No, these points are very valid and very timely in the context of our ambition to revisit and review our previous programmes, plans and strategies, and to consider our experience through COVID in order that we can refresh and update our ambition. One of the ways that we hope to do so is through strategic delivery programmes, high-level programmes that will look at our work in relation to learning disability, mental health, primary care, older people services. These are effectively the mechanisms for us to begin to horizon gaze and to identify what are the new models that we would wish to initiate over the next 3 to 5 years. What are the moves and changes and shifts in resources that would be necessary in order for us to achieve that? Where are we going to disinvest from? How are we going to make best use of earmarked funds that are coming from central government? And how that will support the delivery of the IGB's strategic commissioning priorities. So we would anticipate bringing back to the IGB proposals and recommendations in respect of that transformation over the course of the next year. And that will feed into both, hopefully, the mitigation of some of the risks that we've identified in our strategic risk register, but certainly, as Pat Kilpatrick has identified, the areas for future investment and disinvestment that will enable us to continue to maintain high levels of service delivery, but also to find creative ways of working around the significant challenge. And I think Pat's absolutely correct that the most significant challenge for us moving forward, which impacts on a range of our activities, is around workforce. So it won't be the case that we keep going out to try to recruit doctors, nurses, social workers and social care workers who aren't there. We need to find other ways of addressing that. Now, the challenge around workforce is very complex. We are clearly impacted on by what's happening at the national level in terms of succession planning and the pipeline for bringing through qualified and experienced practitioners. We're equally impacted on by how effectively we are able to advance this work with our statutory partners, who, as colleagues will not need reminded, are the employers of that workforce. But within that, there is certainly a lot that we can be doing that's within our scope and our control that we'll be seeking to do so. So hopefully that provides a bit of a reassurance and a bit of an answer around, for members of the Audit and Performance Committee who've been on the IGB for a bit longer. Essentially, this is about us revisiting our transformation plans and looking, as we did previously, at where do we want to be in 3 years' time and how are we going to get there and how do we shift resources in order to achieve that.
Okay, thank you, Chief Officer. And I could perhaps suggest that I'm sure this is something you're considering already, that through a development session or such like, that it might be a good way of having that initial discussion with board members prior to taking anything to the board. Okay, so we've got a question from Mr. McPherson.
Thank you, Chair, and thank you also to Jane and her team for that scene-setting presentation, which was certainly helpful for me and I'm sure for others. I had 3 questions actually, Chair, but they're all interrelated, so it probably makes sense if I go through them in one with your permission. And it's really around things that I might have expected to see differently in the numbers and just to understand the reasoning. There's a couple of areas where there were underspends. I mean, the first in adult services, where there's an underspend of around 200,000 in general adult psychiatry and learning disabilities, and that was attributed to vacancies. But what I might have expected to see was that being offset by additional costs on locums and contract care, and it would appear that didn't happen. The second point is a linked one, and it's around in older people's services. Again, we saw an underspend in relation to residential care costs for reasons that we can understand, that people were not wanting to go into that environment if they could avoid it. But we also had an underspend on the care at home budget, where again I might have expected an underspend on residential care to be offset by an overspend on delivering care within the home environment. So I suppose on both of these points, I guess I'm just looking for some reassurance that we continued to deliver the services that our patients were expecting. And my third question was just around, there's an item around the savings plan which undershot during the year for reasons that again are perfectly understandable. And I see that was so 1.4 million of savings were not achieved during the year, and I see we bagged that as a COVID cost. I suppose if I were Scottish Government, my argument might be that savings aren't achieved for lots of reasons, not necessarily because of COVID. So I was just wondering what degree of comfort we have that that will or has been met as a COVID cost. So hopefully these questions can all tie together. Thank you.
Okay, thank you very much for those questions. So we'll maybe take them one by one. So the first question was about the underspends in general adult psychiatry and learning disabilities. So I'll ask the Head of Health to speak to that.
Thanks very much, Chair. In relation to the underspends and the offset against locums and contract agencies, so as a HSCP, we don't oversee, for example, the medical workforce in GAP and LD that is attributed to inpatient mental health. So therefore you wouldn't see locum or agency costs within our budgets. We have done a bit of a deep dive into our POA and our GAP budgets, and technically this is just slippage in terms of the timing for recruitment. 200k isn't a massive amount. It's about attributed to about 4 posts, and it's very difficult to recruit into locum mental health or LD posts, people with experience or nurses with experience. So that's potentially why we wouldn't do that. So I think in relation to locums, yeah, we don't hold the budget for the medical staffing. So that's really where that's coming from.
Does that answer your question, Mr. McPherson?
Yes, thanks on that one. Thank you.
Okay, thank you. So the second one was about the older people services and care at home versus residential care home placements. Zoe Robertson, do you want to answer that one?
Sure. I suppose I would agree with you that you would naturally assume that care at home delivery would increase actually as the care homes decrease, but it's just not what we saw, and families actively chose to not receive care at home delivery. So it's not that we took away services from people that we thought needed the service, but families made that choice themselves. And I suppose the consequence of that is what we're seeing now, though, is that people who are coming into services are more dependent, more unwell, and in need of bigger packages of care. So that's really the situation that we have found ourselves in. But as I say, we increased other areas of support to try and ensure that those who were isolated at home received support through community support and volunteering and a whole host of other community-based support services as an alternative to a statutory service, as and when they were happy to have people come in. And that might just have been through telephone support to reduce isolation, a number of different smaller projects that have been really highly valuable during that pandemic.
Okay, thank you. Is that okay, Mr. McPherson?
Yeah, thank you, Zoe. I mean that's the reassurance that I was really looking for, that we found other ways of meeting the needs of people who wanted support. So yeah, thank you.
Okay, thank you. And then finally, we had the question on the savings realised and the COVID costs. Now, I know this is something that's come up before, the extent to which we could use COVID monies to offset these costs. Chief Financial Officer, do you want to take that one?
Yes, thank you, Chair, and thank you for the question. The savings slippage, way back at the start of the pandemic, it was very clear to us on the ground that the capacity of officers to focus on major transformation whilst responding to a global pandemic was going to be significantly impacted. And there was a lot of discussion with the Scottish Government at that time that there would be a requirement to bridge savings delivery, and yet that was then built into the Scottish Government guidance for 2021 that slippage on savings could legitimately be covered by additional budget from the Scottish Government. Interestingly, for 21-22, that position has shifted, and as things stand, we at this point are not expecting to have slippage on savings covered, but we are still pressing that point because we are still responding to the different aspects of the pandemic, as we speak. Well, the one point I would make, Donald, is that you're absolutely right. We had a shortfall of 1.4 million, but in the face of a pandemic, we achieved £2.5 million of savings regardless. And that was despite a pandemic, and I think that's something to be celebrated. The fact that we still managed to achieve such a significant sum.
Okay, thank you, Chief Financial Officer. Is that okay?
Yeah, no, thank you, Jane, and certainly, for the avoidance of doubt, I certainly wasn't wanting to denigrate the savings that have been achieved, and in the circumstances. It was really more just a question around the being able to book the ones that we didn't make against COVID costs. So that explanation of the Scottish Government position is very helpful. Thank you.
Okay, thank you. Right, next I have a question from Councillor Duff, then to be followed by a question from Mrs Summers.
Thanks, Convener. Yeah, I think my question was partially asked and answered in the question you put yourself to Mr Patterson, but my comment really was around about the lack of sort of corporate capacity. We've had these issues in the past, and we've talked this morning about what we would like to do in terms of building back better, I think is the kind of expression. But in order to take advantage of that, I think we have to ensure that corporately we are structured in a way that can achieve that as quickly as possible for the way ahead. So so I say, I'm not sure it's a comment or a question that I have, but I think we need to ensure that we have the right corporate structure to take advantage of the lessons learned in terms of the way ahead. Thanks.
Well, it might not be a question, Councillor Duff, but the Chief Officer wants to answer it, so I'll let him do that.
Apologies, Chair. I could have let that go. We will be picking this up in the context of the feedback that we give around the Partnership Improvement Plan and the Strategic Risk Register. But absolutely, just to reflect back to Councillor Duff, that certainly at the height of the pandemic, our exposure and the lack of capacity was acutely felt. The way that we sought to mitigate that, though, was through retasking and by focusing our finite resource on the highest priority areas that we needed to deliver on, and I think that we did that really, really effectively. As we are now beginning to see our way out of the second wave and hopefully not into a third wave, although we may wish to recognise the increased number of community infections, I am advancing the plans around restructuring the Health and Social Care Partnership. We've had a couple of meetings within the executive management team, and I've put together a project team involving our colleagues in both statutory partners, HR departments, and the staff side and trade union side. That seeks to address some of the outstanding recommendations from the inspection report. It seeks to address some of the capacity challenges that have presented difficulties for us. And that, combined with the review of the integration scheme, where we will be seeking to achieve greater clarity on the level of corporate support that is provided to us by the Council and the NHS relative to that which we have in-house within the Health and Social Care Partnership should enable us to move forward with this long-standing challenge that the partnership has experienced probably since its inception, and which has been highlighted in audit and inspection reports. So that is again a work that we are seeking to progress, and I would like to do so with a degree of pace given where we're at, and the need to move forward with some of these higher level transformation plans that we referenced earlier. Thank you.
Thank you, Chief Officer. So next we had a question from Mrs. Summers, I think, for the Head of Health.
Yes, it was more a comment. It was about the question that Donald asked about the 200,000 underspend for the GAP services, and the reply was that, well, that's not in our budget, that's in the inpatient services, like, you know. I think we have to really consider as well the overall effect it's having on the budget for NHS Tayside. And, you know, this has been a problem. The locums have been a problem for at least the last decade while I've been involved, and never resolved. We're heavily relying on locums, and as long as we're spending all this extra money on locums, it's going to be hard to, you know, recruit the amount of staff that we actually need. There was some talk about a meeting I was at recently about restricting the time that doctors can actually remain working as locums in an area. If they had a restriction on that and then told, well, you need to accept a post here, you know. I don't know whether that would be taken away from their human rights or something stupid like that. But I mean, something's got to be done to restrict that, because it's just eating up budgets, whether it's this budget or another budget. It's the overall Tayside budget that's been affected here, and we're not really moving forward with the problem. So I just wanted to make that observation, and what we're actively doing to change things, you know. How are we trying to publicise and attract people to Tayside? Is it in the British Medical Journal? How far afield are we advertising? But, you know, something needs to be done to address this, because it's been going on for too long now, like, you know. So just a comment.
Okay. Thank you. Mrs. Devine, there was a few questions in there at the end. Do you want to put anything to that?
Yeah, it's just a point of clarity. I suppose what we were talking about was the £200,000 underspend in the mental health family, Maureen. So that's, you know, it's psychiatry of old age, inpatient and community services, learning disability services, and CMHT services. So it's a much broader spend around that. So I think it's important to recognise that it isn't all impacting in terms of the CMHT services. In relation to recruitment, my understanding is we've gone internationally for recruitment in relation to medical staffing. So there's been a huge push over the last period of time to look at medical staffing, and there has been a level of stability that has been brought to the service since we've had Mike Winters as the Associate Medical Director in there. But as a partnership, we have just approved the move forward in terms of advancing the advanced nurse practitioner roles, which is something that will go some way to supporting the sort of medical interventions moving forward. So we are beginning to progress with different models of care that will make a difference in the longer run, and that will be across adult mental health, older people, and learning disabilities in the longer term. So that we are beginning to look at different types of interventions, and along with, you know, support in relation to where we need to go with our specialist AHP family as well in terms of OTs and physios. So I think we're beginning to try and change the models of care to support in a different way.
Thank you.
Sorry, will that mean that outcomes can be eased out then? As these advanced, will we be able to ease locums out then, you know, because, you know,
yeah, an advanced nurse practitioner doesn't take over the role of a consultant, Maureen, but what they can do is work hand in hand with a consultant to reduce some of the activity that they have to do it currently. So it is a more of a blended model.
Okay, and I think the Chief Officer also wanted to make some comments. I'll maybe let the Chief Officer come in, and then Mrs. Summers, if you have any further points, you can come back.
Thank you, Chair. Evelyn partly answered what I was going to say in terms of looking at advanced nurse practitioners as one way of offsetting some of the challenges that we're experiencing. I think it's probably though worth just noting and advising the committee that NHS Tayside is currently recruiting for a director for mental health and is at the stage of shortlisting. That advert's now closed. And this would be a post that would replace Kate Bell, who was here as the interim director. Last week, or in the last couple of weeks, NHS Tayside has appointed general managers in relation to mental health and learning disability, particularly focusing on the work on inpatient services. And there is a further advert out at the moment for an associate medical director for mental health, and I think there's also the intention is to appoint a lead nurse for inpatient mental health and learning disability services, to work alongside Keith Russell as the Associate Medical Director. So there's significant activity underway. One of the challenges that we will seek to address in relation to recruitment, one of the ways in which we'll seek to address some of the challenges that you've identified in respect of recruitment, Maureen, is around the development of our community mental health strategy and the workforce requirements that are necessary in order to underpin a move towards more early intervention, prevention, community support, and supporting people to remain well. So there'll be a raft of measures that will be brought forward in that strategy, which would supplement and complement where we need qualified medics and nurses, AHPs, social workers. But absolutely, this is a significant challenge. It's a challenge locally, it's a challenge nationally, and as Evelyn said, we have sought previously to recruit internationally. Hopefully though, with the development of these new posts, the investment and consolidation in order to build on improvements, we'll get to a position where we won't be as reliant on locum doctors, because NHS Tayside will be better able to recruit people who recognise that this is a priority for the NHS moving forward, and will see it as a more attractive option when considering future career choices. So there's a number of pieces of work underway, a bit of progress is being made, and other plans are being advanced, which hopefully will secure a stronger position moving forward. Thank you.
Thank you, Chief Officer. Mrs. Summers, were there any further points you wanted to make?
No, there's lots I can say, but it's maybe more appropriate at a mental health strategy meeting than here. You know, I feel I've maybe taken up enough time, but I was really concerned about the locum position, like, you know, not progressing over a number of years now. But it's good to hear that these, you know, appointments are in the pipeline, so that's good. Thank you.
Okay, no, thank you. No, it's a very important issue, so it's good to keep it on the agenda. I'll ask.
I wonder if I could just come in and add to what Gordon has said. Yeah, sorry, it's not letting me use the chat function, Chair, so I apologise for interrupting you. But Gordon's put you know, he's outlined all the actions that have been taken. There are a lot of very positive things going on. I think we've probably said this before, Maureen. It's actually a national. If you read the BMJ, right? I'm fortunate. My daughter's a medic, and I get the BMJ at the house, so I read the medical press. I'm interested in it. The Royal College of Psychiatrists are not going out of their way, let us say, to encourage young people to go into psychiatry as a specialism. That's the main problem, and NES, National Education Scotland, are not doing anything to make psychiatry a more attractive subspecialty area for young doctors. Therefore, young doctors are not going into training psychiatry. That has created a national shortage of psychiatrists. This has been going on for 10 years probably. There's a national shortage, and actually we are very, very lucky, and it's a testament to people like Gordon and to Mike Winter and to Kate Bell, the girl that was here before, that they have actually managed to find these locums, because locums are like hen's teeth. You just can't find them. You can't find good, you can't have unsafe locums. You can't just put somebody in post because they've got some qualifications or some experience. They've got to be safe for the patient. Otherwise, you know, we wouldn't be doing our job properly. So it's a huge problem. It's a national problem. And as Gordon said, the answer is not, we can't replace advanced psychiatrists with advanced nurse practitioners, but if we can have a more blended approach, that will certainly help. But don't expect this to be solved anytime soon, because I have to be honest, I don't think in the press, you know, what you read about in the press and the media, it doesn't look, it takes 6 years to take a doctor from FY2 to train them in psychiatry. So even if we turned the tide now and thousands of people wanted to get into psychiatry, which seems unlikely, but if that were to happen, it would take 6 years for them to come out the other end, Maureen. So we're going to be living with this problem, I think it's fair to say, Gordon, for quite some time. But a great testament to all the efforts of people locally who've done as good a job as they have, I think, in their defence. I hope that's helpful, Chair.
Okay, thank you, Mrs. Kilpatrick. And I noticed you talked about NHS education for Scotland there, and we do know the chief executive, the new chief executive there. So perhaps that's something that the chief officer could pass on to her as a constructive suggestion. So thank you for that.
Absolutely.
Okay, I'll just check if there are any further questions or comments that anyone would like to make on this paper. No. Okay, well, thank you everyone for your contributions to that. We'll move on to item 4.2, which is the Key Strategic Performance Indicator Report for the period from December 2020, or to December 2020 rather, which was Q3 of 2020-2021. There was an appendix here, which I note has just been circulated in relation to the deep dive work that was going on about some of the indicators and the way NHS Tayside was recording them. So perhaps Chief Officer and Mr. Jolly, when you're introducing this report, if you could go into a little bit more detail about that, given that that appendix has only been circulated now, if that's okay. Thank you.
Thank you, Chair. I was actually just going to introduce Chris Jolly to speak to this item, but your point's well made. That appendix relates to the recording of readmission rates, and that was one of two indicators that the Audit and Performance Committee were keen to hear a little bit more about, the other being the increased number of falls that were being reported. So those would potentially be issues that Chris could pick up in his presentation. I'll hand over to Chris Jolly. Thanks very much.
Thanks very much, Gordon, and thank you, Chair. I'll keep this brief, as you'd suggested at the start of the meeting, Chair. So the performance report builds very much on the previous quarter and the various previous quarterly reports that we brought forward to audit performance throughout 2020 and into this year, and these will build towards our annual performance report that we'll bring forward later in the summer. Excuse me, the performance across 2021 very much needs to be considered in respect to the COVID-19 pandemic, which has obviously seen significant variances against previous years in respect to demand on services and the activity that those services have undertaken. Bearing this in mind, however, and also bearing in mind comparisons to Scotland, P&K performance overall against this core set of integration indicators has met or exceeded the target in all but two of the indicators, and I think Gordon and perhaps yourself just mentioned readmissions and falls, and I'll go into those just in a little bit more detail just in one moment. The point I wanted to make just before we go into those was the comment in the paper around the annual performance report being slightly delayed past the statutory deadline of end of July. And just to bring that to the attention of the committee, There is a Scottish Government extension to allow us and other public bodies to go beyond the statutory deadline, and that's highlighted in the paper. So in respect to the two indicators that have been highlighted here, the taking first of all readmissions, so a significant amount of work went in to the investigation of the readmissions data over the past couple of years. This was previously investigated by colleagues in Dundee HSCP, and building upon that work, what we've been able to establish or re-establish and reconfirm is that much of the issue here relates to the manner in which NHS Tayside codify admissions and day patients and outpatients, and there is a variance in how that is done in Tayside, which is different to how it's done substantially across the rest of Scotland. So that in effect predisposes Perth and Cross HSCP and the other HSCPs in Tayside to appear to have a higher level of readmissions than could be expected when considering Scotland. As a comparator, when we look at previous performance against this particular indicator, we were able to investigate using the methodology that's articulated in the paper that's just been circulated, and please accept my apologies for that not coming beforehand. I'm not quite sure where the omission has occurred, but it's been circulated now, and I would be happy to receive further questions on this briefing paper if members are not able to read it quite understandably within the course of the meeting. But returning to my point there, looking at the readmissions data for previous years, once we factor in the particular demography of Perth and Kinross, any population may be expected to have readmissions within 28 days, for bearing in mind these readmissions may relate to anything and may be in no way connected to the reason that the person was in hospital in the first instance. Within any population, you may expect readmissions of a certain rate based on the demography of Perth and Kinross and the particularly unique age demography. Once those things are factored into account, the readmissions rate within Perth and Kinross is not beyond what may be expected. So moving on to NI16 and the falls rate, we are conducting a further investigation. I think as excuse me, as I've indicated previously, it's proven a little bit more difficult than the readmissions investigation, and that's purely around trying to marry together data from within NHS Tayside and our statutory partner Perth and Cross Council, so that we can understand to the greatest extent possible a number of factors in relation to these falls. I think we can see from the data, however, that there's a very marginal increase in our performance from previous years, with that 0.81% increase. The other thing that needs to be borne in mind, particularly in relation to falls, is the numbers are very low, and so small movements can make a significant change in percentage. And we'll happily report back to the committee in the future as we develop our investigation into the data behind that. I'll just pause for questions now.
Okay, thank you very much for that, and thank you for undertaking this work and following on previous questions and discussions at the Audit and Performance Committee. It's very welcome to have more detail on that. I do have a couple of questions, but I'll first ask if there is anyone else who has any questions or comments that they would like to make on this paper. No? Okay, well, I'll start with mine, which are questions I already asked at the pre-agenda meeting, but it was just to air them in the public committee, if that's all right. The first one was about the other indicators. Obviously, these were some where we were not performing quite as well. So we wanted to look and see why the reasons for that were. Just wondering whether we think there might be other areas where we are performing or seem to be performing better, but the NHS Tayside might be recording it in a different way, which could lead to different results if that were rectified.
So yeah, thanks for the question, Chair, and following our previous discussion on that point, I have been in contact with our Public Health Scotland list colleagues who obviously engage with wider than simply within Perth and Kinross, and they weren't able to avail me of any information that would suggest that there are areas that we would need to be concerned about in the manner that you've asked.
Okay, thank you for that. And just the other question was, before I bring in Mr. McPherson, in relation to going forward on some of these indicators, is the intention that NHS Tayside will bring their practices in line with the rest of Scotland, or is that something that's still up for discussion?
So yes, again, thanks for the question. There's a significant review across Scotland of the manner in which a number of these indicators are recorded, and working with our colleagues in NHS Tayside Business Unit particularly, and across Scotland to go through that consultation process. I can't give the detail on these two specific PIs, but as part of the consultation that we're going through, we have raised those particular issues, and I think what we can certainly expect is that as we go through 2021 and 22, we may see a significant movement in a number of the indicators, and that those movements would be related to a change in recording practice, which we're very much keen to ensure is taken forward on parity with the rest of Scotland, so we'll certainly influence that to the greatest extent we can.
Okay, thank you. Right, I'll bring in now Mr. McPherson, who has a question.
Thank you, Chair. Just a brief one. I was interested to know to what extent do you break down Perth and Kinross into different areas to access the data, because I'm sure that Perth city centre is very different from Kinlochrannoch, for example, and I know the other IGB which I'm involved in, we do analysis by ward, and sometimes that can help bring out trends. I mean, for example, around the falls issue, that sometimes the picture becomes clearer when you drill down to the next level.
Yes, Mr. McPherson, thanks very much for the question. We do indeed, on a month-to-month basis, separate these performance indicators so that we can indeed look at them on a more granular level, so that we can understand just exactly the point that you're making. So I'm not sure how that in itself answers your question specifically, or whether you wanted more than that.
I suppose the follow-up then is, in what way does that data come up to either this committee or the IGB to give additional visibility?
So the performance framework that the Health and Social Care Partnership is continuing to develop, but has in place currently, has an agreed set of performance indicators that we bring forward to the committee, which are these ones, and we haven't sought to bring forward additional indicators at this stage.
Sorry, I suppose I wasn't looking to put in additional indicators. I was more asking for whether the existing indicators might be broken down by different regions. I mean, I'm conscious I'm a here today, gone tomorrow member of the committee, so it's perhaps one for the standing members to think about.
The Chief Officer wants to come in.
Yes. I mean, I hope you're not gone tomorrow, Donald. It's very helpful that you're involved, and I'm grateful for your attendance today. And it would be important, if at all possible, to try to encourage you to be involved in some of the development sessions and the other activities that the IGB is progressing, particularly in the event that you need to step in for Mr. Erskine again. No, it's a really important question. There's a couple of things that I would wish to add. Like all health and social care partnerships, we are required to have to deliver our services in the context of localities, and in Perth and Kinross we have the Perth City locality, we have a North locality, and we have a South locality. In addition to these high-level indicators that are being considered today by the Audit and Performance Committee and feature quite prominently in national reporting through the annual performance reports, we are developing a suite of indicators at the next level down that might say more about outcomes than about output. So those are currently being refined and developed by operational colleagues and are reported to our executive management team. We have recognised that we have a long way to go from when the joint inspection highlighted this is a significant deficit in our activity as a health and social care partnership. The indicators that are presented today are part of that journey, but there's an awful lot more that we want to do, and we are already doing so. But at the moment, that is being looked at by officers. It's perhaps slightly more operational than we would escalate to the IJB. But if there are themes or trends or issues that we require to draw to members' attention, we will absolutely do that. The other thing I would want to point out is that we have a commitment within our budget to look at how we can develop some resource to build on work that was previously done, quite pioneering work in Perth and Kinross around something called the Integrated Resource Framework. This will enable us to do very detailed analysis by locality and by GP practice on levels of consumption of health and social care services, and to overlay that against areas of multiple deprivation. That will give us a much clearer picture on issues around health literacy and on inequalities, on spend, on inequality in spend, including in relation to our prescribing budget, because what we would like to see is a reduction in our prescribing budget and a commensurate increase in our investment in community services, social prescribing, early intervention, health promotion services. So there's a lot going on in this area, and we will be looking forward in future to bring further reports back. It is always that tension between providing the IJB with far too much operational detail and aligning some of this work to the high-level strategic priorities of the board as our governance board. Thank you.
Thank you, Chief Officer. Can I ask members if there are any further questions or comments on this report?
Chair, can I come in here? I know I haven't got a hands function on this.
All right.
I don't know why, but I don't. I think just sort of adding on to the comment that Gordon's just made, I think for me as an IJB member on this committee, the most glaring deficits I think are that we are not reporting any performance at all on mental health, which is a mystery to me, given that in the last 2 years we've spent more time talking about mental health than we probably have any other service, but we're not reporting anything on performance of mental health or learning disabilities, given that we've had inquiries and we've had investigations, and we've had development days and we've had strategies and we've had stakeholder engagement. I still do not know if a patient is discharged from inpatient care in Perth and Kinross, how long does it take on average for them to be seen by the community mental health team? Now that is an important aspect of performance. We report the same thing every meeting about readmission rates and percentage of over 70 PIs being non-elective admission to hospital, whatever it is, but we never report anything on mental health. And we don't report anything on public health either. I couldn't really tell you. I mean, across Scotland, Scots die from 3 things: coronary heart disease, cancer and stroke, but I couldn't tell you what they die from in Perth and Kinross. I can't tell you the mortality rates, the morbidity rates, the cancer incidence, the incidence of coronary heart disease. We are not reporting anything on public health, and we are not reporting anything on mental health. And I think these are 2 glaring deficits in our performance reporting. Thank you, Chair.
Okay, thank you for that, Mrs. Kilpatrick. And I think that's a fair challenge. We did have a discussion at one of our previous pre-agenda meetings and with the Chief Financial Officer about the indicators that we have and the usefulness of these indicators, because it is something that I've raised before, that these ones, while we obviously have to monitor them, the Scottish Government indicators, that doesn't necessarily, it isn't sufficient for our needs. Obviously, there are concerns around the hosted services, and we have had discussion before about how best to report those, not just mental health, but some of the other ones that we have too, because there are some that we provide for other IJBs and vice versa. So I think that's certainly something that I'm happy to take away and see if we can address some of those concerns that you have raised, because I think that's a fair challenge.
Yeah, thank you. I totally agree with you, Chair. Thank you.
Okay, thank you for that. We'll move on then to the next section of the agenda, section 5, which is governance and assurance. And the first paper that we have is item 5.1, which is the strategic risk management update. And I think the Chief Officer is going to speak to this one. Is that right?
Yes, Chair. Thank you very much.
Thank you.
Yeah, so item 5.1, strategic risk management update. The IJB regularly receives reports on our strategic risk register, and most recently we had a discussion at the Audit and Performance Committee about the need to develop a strategic risk improvement plan, which is included within this report at Appendix 2. Members will also note that the Executive Management Team is routinely reviewing the progress in relation to our 13 strategic risks, according to the level of priority that they have. Section 3 of this report provides members of the Audit and Performance Committee with an update in relation to how our strategic risk profile and level of risk exposure has changed since we last reported. And that is summarised in a table on page 37 of the report or of the papers. Members will also wish to revisit the full strategic risk register. Many members will be familiar with this. The 13 strategic risks are as previously agreed, and obviously we have provided an update in relation to their current status when we factor in control and mitigating measures. Finally, in relation to section 5, members of the IJB will recall that they approved the Tayside Risk Management Strategy, which is the way in which we work in a coordinated fashion with colleagues in the other health and social care partnerships and also within NHS Tayside and Perth and Kinross Council. And just finally to acknowledge, as the Chair mentioned earlier, in view of the discussion that took place in February, I think, when we looked in detail at the strategic risk register, we have set up, or we're intending to set up, an IJB workshop to look at risk and risk appetite, risk tolerance with IJB members later in the summer. So hopefully members will have that in their diary and be able to attend. So I would draw members' attention particularly to the strategic risk improvement plan, and I'm happy to take any questions in relation to any of the particular risks on the register.
Okay, thank you for that, Chief Officer, and it's also welcome to see the improvement plan that has been included this time, following on from the discussion at the last meeting as well. It's certainly a very useful document to monitor the risks that we face as a partnership. Can I ask if there are any questions on this report? No questions? Okay, any comments?
Chair, I have a question.
All right, Mr. Kilpatrick.
Yes, apologies, I know you can't see me put my hand up. On the strategic risk number 11, resolve insufficient, suitable and sustainable premises. Right, we may not be able to provide all the services as defined under the JMS contract for 2018. We have discussed this before at length, And it would seem that it's not just important just to identify the risk. Of course, that's important to identify the risk, but I think probably more importantly is how do we address the risk? And one of the would appear to be essential, I think, in going forward with this work is to have an estate strategy for primary care premises. We need to have a strategy for primary and social care services that says, how are we going to provide over the next 25 years for the population, rural and urban, of Perth and Kinross? What facilities do we need? What, whether that's community hubs or, we're not, unless we have a strategy, we're not going to be able to submit business cases to Scottish Government for money. Now, I've been involved in another part of my professional life in 8 health and social care centres in other parts of the country, including Grampian. Now, the government wants to spend money in primary care, primary and social care, and these centres roughly attract 25 to 30 million pound per development. Now, if other health and social care partnerships can get these business cases, successful business cases, and get the money and get the developments underway, we should be able to do that in Perth and Kinross. Now, whether that's done under the auspices or in partnership with NHS Tayside as part of the wider estate strategy, I'm not sure, or whether it's going to take so long to do it pan Tayside, we should just move on and do something for Perth and Kinross. But I don't think we can just keep reporting it as a risk when we don't have an estate strategy to address it. And I think that's becoming really critical at this stage in our development as an HSCP. Thank you, Chair.
Okay, thank you. The Chief Officer, I think, wants to answer the question.
Thank you. No, it's a very important question. So I would be able to provide some reassurance to Patrick that we are developing a primary care strategy, which is looking both at workforce and premises. And this is a Perth and Kinross Health and Social Care Partnership strategy. What that will do is it will present a challenge to our statutory partners, because a health and social care partnership can't enter into leases, it doesn't have a capital budget. It is really essential that NHS Tayside assume their responsibilities in this regard, and that features into the work of NHS Tayside's emerging capital plan, that isn't focused exclusively on hospitals and robots, and it looks at primary care services, primary care premises, and the provisions of the GMS contract, which in the coming years will require NHS Tayside to provide that accommodation to independent contractors, to GPs as independent contractors. So I've had a meeting with the new head of estates and with the director of property and the head of estates in NHS Tayside and the director of property in the Perth and Kinross Council. We have made urgent requisitions in relation to those situations that are causing us the most concern in terms of the provision of property or premises, and we have alerted them to the fact that we are developing this strategy and would be looking to present it for consideration by NHS Tayside at the earliest opportunity. A couple of things about that. Inevitably, it's been delayed because of the pandemic. It's being led at the moment by Hamish Dougal, our primary care manager. Unfortunately, finished up with us a month or so ago. So Hamish is overseeing that work along with everything else. But that would then have to be considered by NHS Tayside Primary Care Infrastructure Group and then fed into the capital plan. There isn't a lot of focus on community services within the capital plan at the moment, and that will be something that we'll be encouraging colleagues in NHS to consider, and will no doubt be something that NHS board members will be asked to consider in terms of the opportunities to draw down funding from Scottish Government in order to enable them to mitigate and support the activity that we're seeking to take forward. So absolutely, it's work that we're progressing. We have had that positive engagement with the new Director of Facilities in NHS Tayside. He understands that there is a clear responsibility on the part of NHS as statutory partners to meet those demands, and we are looking forward to progressing that work over the coming months. Thank you very much.
Thank you, Chief Officer. And Ms. Kilpatrick, are you happy with that?
Yeah, I mean, I'm happy with, and I know it's been very difficult, Gordon, and I know NHS side has to take a lead on this, but I think it would be useful if you started to develop, and it sounds as if you are with Hamish, a kind of, you know, feasibility study maybe of your top 2 or 3 priority areas, and work through a feasibility study as a signifier to NHS side. Look, we've got some schemes that we think could, you know, would be a runner, and we've done some preliminary work on this, and that's something to build on. I think it's always good to get your tuppence worth in there first, and you know, have done a bit more preliminary work to show that there is a good argument for a business case and a good argument for investment in Perth and Kinross in that part of our infrastructure. But yes, I can see that people want to do it, but it just upsets me that I see other people getting money for things that I think, well, why are we not getting that money? And we're not getting that money because we're not putting business cases in. Thanks, Chair.
Okay, thank you, Ms. Kilpatrick. And before I come to Mr. McPherson for his question, I think Councillor Drysdale wanted to make a comment on this issue.
Yeah, thanks, Chair, and just wanted to make a comment on this most recent question and answer that Gordon's given. It strikes me, you know, as you know, Pat, I'm also on the NHS Tayside Performance and Resources Committee, which you chair, and it strikes me every time I attend that meeting, and we're in a different meeting here, the focus that there is on 9 wells and PRI and so on, and new technologies, etc., and comparatively little in terms of the community investment in estates, etc. You know, and you'll recall that I've asked comments about, for example, GP services in Bridge of Erne, which is something that was flagged up a year or so ago, and you know, I think it would be useful to take this whole estates investment discussion offline as well, and perhaps yourself in your role with the Performance and Resources Committee of NHS Tayside to take forward Perth and Kinross IJB's concerns, if I might be so bold, as to the very issues that you describe, i.e. the need for investment in estates within this locality. I don't know how best to take that forward. That's just my own off the cuff comments.
If I could come back in, Chair, I would totally agree, and I'm happy to discuss it offline. I have raised it with the new Estates Director, and I have raised it at PNR, and I'm very supportive of ensuring that we get the proper investment into primary and social care services in our communities, and a special praise for Perth and Kinross in terms of that discussion. But we do have to have identified, we have still got to do the preliminary work. Where do we need it? What would it look like? What would it provide? Why would it be unique? Why would the government invest in that? We need some of that. It's one of these chicken and egg. Do you start to do some work in it and then go forward to the meeting, or do you go forward to the meeting and say, look, we've already looked at this and we've got 2 or 3 schemes which we think are absolute front runners. So I'd be happy to talk to Eric offline and discuss it further. Thank you, Chair.
Okay, thank you. And I think also the Chief Financial Officer wanted to make a comment, I assume, on this issue.
Yes, thanks, Chair. I do feel it is necessary, Pat. You have talked about you know, setting out a business case for proper investment in our services, and that requires an investment in corporate capacities to support us to do that. And for as long as NHS Tayside focus the corporate capacity that they've got on their priorities, that corporate capacity that they have a responsibility to provide to us to develop that business case that you're asking us to set out is not there for us. So the question for us as a board is, do we need to grow our own corporate capacity? Because at the moment we are reliant on what they can give us, and at the moment it is diverted elsewhere.
Okay, thank you. Right, we'll maybe draw that discussion to close, and I will ask Mr. McPherson for his question.
Thank you, Chair. I was going to move on to a different risk, if I may, which was strategic risk 7 around preparedness for pandemic pressures. Now, and I noticed in the report that it talks about a review of the command structure that's taken place. I wasn't sure whether that was Perth and Kinross level or at NHS Tayside, or Tayside generally level, but I think that's really important because it's the first time I think this sort of command structure will have operated on the scale it has across the pandemic, and I'm sure there will be lots of lessons learned out of that at a governance level. So I'm wondering to what extent will any feedback from the review come up either to this body or alternatively to the parent bodies. I think it looks like Gordon can answer that one.
Okay, Chief Officer.
Thanks very much, Donald. Yeah, it does pertain particularly to a review that we're carrying out in relation to Perth Kinross Health and Social Care Partnership command structure. I had the fairly unique experience of being involved in the command structures of Perth and Kinross Council, NHS Tayside Gold Command, and obviously also in relation to the Health and Social Care Partnership. And it is interesting to reflect on the similarities and the differences in the approach. That provides, as you've identified, absolutely very rich learning that can inform the development of our response and responsiveness in the event of further COVID-related pressures. It is probably worth recognising that what we are seeing and what we have seen are different manifestations of the pandemic and how it impacts on our communities, citizens, services and staff. The first wave was very much about us planning for the worst and hoping for the best and quickly moving into response mode when the pandemic arose. And we created a command structure that was agile and able to respond where things were escalated from bronze into silver into gold, and we had various subgroups as necessary. The second wave, which we saw just at the turn of the year, was slightly different in its manifestation, significant impact on hospitalisations and community services as a result of the new variant. And we had both the benefits of our command structure experience at first wave, but we had also developed an outbreak management plan which enabled us to reflect on the experience and lessons when particular situations had arisen that stood us in good stead at the point of the second wave. I'm reluctant to describe the current situation as the third wave, but what we do know is that there are significant increases in numbers of cases of people with COVID in the community, and the figures either match or outstrip where we were perhaps in January. The difference is inevitably that the vaccination programme is thankfully ensuring that fewer people who are testing positive are becoming unwell, and we're seeing fewer admissions to hospital and in turn to intensive care units. But what that might mean is that we have to develop and adapt our previous approaches in recognition that we may now be in a position where at any time we might have to expect large numbers of people to be COVID positive. And whilst thankfully, as I say, they're not becoming unwell, that does have implications for how we deliver services. It certainly has implications for our staff who may have to self-isolate because they've been in contact, may themselves be positive, or maybe looking after school-aged children. The review of our command structure will provide some really rich learning from those various experiences, and absolutely we will be looking to ensure that that can inform any similar work that's being advanced either in the council or within NHS Tayside. So yeah, it's really important that we reflect on this. The other way in which we have to reflect on it, which I should probably mention, is that we're also now, as IJB's Category 1 responders in relation to the Civil Contingencies Act. And whilst that was a more recent development, from the outset, the Health and Social Care Partnership Chief Officers have been active participants in the Local Resilience Partnership, and we can learn from it, and it can learn from us in relation to our experience. And the Chief Officers in the north of Scotland are actually meeting with the lead officer from the Local Resilience Partnership tomorrow afternoon to have some of these discussions. So hopefully that answers your question, but further provides a degree of assurance about the work that's underway.
Yeah, thanks, Gordon.
Okay, thank you. Can I just check if there are any further questions or comments on this report before we move on? No? Okay. Right, we'll move on then to item 5.2, which is the Partnership Improvement Plan update, and I'll ask the Chief Officer to introduce this report.
Thank you, Chair. Apologies, I was struggling to get the mic on there. Thank you, Chair. So this report provides an update to members of the Audit and Performance Committee of the progress that we have advanced within the Health and Social Care Partnership in relation to our Partnership Improvement Plan. For the benefit of colleagues who are perhaps less sighted on this, the Partnership Improvement Plan was really something that we recognised that we needed to develop in the context of a number of different inspections, audits, self-evaluations, and we have reported on this on a number of occasions now to the Audit and Performance Committee. It reflects the actions that were identified in our annual review of governance, the self-assessment that we carried out in relation to the Ministerial Strategic Group of Review of Integration, and critically to us, the joint inspection that was carried out by Healthcare Improvement Scotland and the Care Inspectorate. So the recommendations from a number of those actions are captured within our Partnership Improvement Plan. Section 3 of this report indicates the shifts in relation to the RAG status of those recommendations, and then goes on to summarise some of the progress that we've made. You'll see also just before the conclusion that we have identified further couple of improvement areas that we want to advance, and those are now incorporated into the Partnership Improvement Plan, particularly joint discussions around financial sustainability with the respective directors and chief executives of the statutory partners, and the need to further clarify the governance and accountability arrangements in respect of inpatient mental health services. This last point reflects the fact that the operational responsibility for inpatient mental health services transfer to another director within the NHS, but that it's still the case that the integration scheme does describe Perth and Kinross IGB as having strategic planning and commissioning responsibilities for those services. So we are keen that we advance that and anticipate that that will be progressed in the context of the review of the integration scheme. I'm happy to take any questions rather than go through in detail the Partnership Improvement Plan, which is the substantive appendix to this report. Thank you very much, Chair.
Thank you, Chief Officer. And just to say, it's very welcome to see the improvement plan. I know we've had a number of discussions on it and seen various iterations, and to have the timescales as well, and the RAG rating is useful for us as members to monitor the progress of some of those actions that have come out of various reports. I'll ask if there are any questions on the report. No, Mrs. Kilpatrick, I'll check with you, given that I can't see you.
No, Chair.
Okay. Right. Well, if there are no questions, are there any comments? Okay. Oh well. Thank you very much for that, Chief Officer. That's very useful. We'll move on then to item 5.3. which is the update on the audit recommendations. And Chief Financial Officer, are you introducing this report?
I'm going to pass over to my colleague Fiona Lowe, who's going to give a quick oversight of this report.
Thanks, Jane. Thanks, Chair. This report covers all the previous audit actions and what status they're at, and at present we have 1 overdue and 2 that are part complete. All the rest have been completed. So action 34 is overdue, which is in relation to consideration of corporate support, which is tied into the wider organisational restructure which Gordon talked to earlier. I would also note that work is underway on the review of the integration scheme across Tayside, and this has prioritised the review of corporate support responsibilities. And also note that internal audit are due to undertake a review of our corporate support arrangements this year, and we are currently agreeing the scope of that review with them as we speak. Action 41 is part complete, which is in relation to the strategic planning group meeting, a refresh of the remit, the roles, responsibilities, membership, and I would note that they had their first meeting last week. Further meetings are diarised, so that action will now be marked as complete for the next report. Action 58 is part complete, and again this is around the organisational restructure, which was delayed due to COVID, but work has restarted on this and it is hoped to have this completed later this year. That's it for the update. Any questions?
Okay, thank you very much for that. I'll ask members if they have any questions on the update. No? Any comments? Okay. Thank you for that. That was very clear and concise. So we'll move on to the next item, which is item 5.4, and this is the internal audit progress report, and we also have a number of audit reports underneath that, but we'll take each bit one by one. So if I could start by asking the Chief Internal Auditor to speak to the initial paper 5.4.
Thank you, Chair. The first item is, as you say, it's the Internal Audit Progress Report. Since the last report to the Audit Performance Committee, we've continued to undertake planned work, and there are reports on this agenda arising from this planned work. One assignment, which has been alluded to already, relating to corporate support, is scoping at the moment. And we're hoping to complete that piece of work shortly in connection with the partnership, and report hopefully ideally at the next meeting in September of this committee. I'm happy to take any comments on the covering paper if there are any questions or comments before moving on to the substantive papers. The actual audit reports.
Okay, thank you for that. Are there any questions or indeed comments on that paper? No? Okay, well then we'll move on to 5.4.1, which, oh, sorry, I spoke a little bit too soon there. Councillor Duff, you had a question.
Sorry, Convener, not quick enough on the draw there. It was really just in relation to that entry around corporate support. There's no grade against it. Is a grade only allocated at the end of the process rather than at the beginning?
That's correct. That grade comes from the outcome of the work. So as we don't yet have the outcome of that work, it's not possible to provide a grade.
Okay, that's fine. Thank you.
Thank you.
Right, thank you. Okay, I'll just double check there are no further questions before moving on. No. Okay, right. We move on then to item 5.4.1, which is the internal audit report on financial risks. Chief Internal Auditor, do you want to speak to this?
Thank you, Chair. Yes, we have had discussion about financial risks throughout this. This was taken by my colleagues in the NHS Internal Audit Consortium as part of the 2019-2020 Internal Audit Plan. Unfortunately, they're not able to be with us today. The risks in summary, the risks are articulated within the risk registers with actions highlighted to mitigate where possible. This review undertook to assess the effectiveness of two particular control objectives, one around the IJB's understanding of the risk and appropriate engagement between the IJB and its statutory partners regarding long-term sustainability. Overall, internal audit concluded that moderate assurance could be placed on this area, which means that an adequate framework of key controls with minor weaknesses are present. There are no fundamental actions which are arriving out of this review, but there are three significant actions which are captured within the action plan. One is complete, and one is marked as complete to the best of the ability of the partnership. However, this action is not within the gift of the IJB alone and does pertain to actions, and it is reliant on actions from the statutory partners. I'm happy to take any questions or comments on this report. If I'm not able to answer any specific detail because it was undertaken by our NHS colleagues, I will take them back and feedback as required to the committee.
Okay, thank you very much for that. And just before we open up for any questions, I just wanted to highlight, as we had discussion in the pre-agenda meeting, that if members of the committee are content, I would like to suggest in relation to that third action that's been identified about some of the outstanding issues in relation to our relationship with the partner bodies and things that need to be addressed, that the committee write to say that this has been highlighted in the internal audit report on financial risks, and that we would again encourage the partner organisations to support us in trying to come to a resolution on these issues, notwithstanding the fact that significant work has already been undertaken on that, particularly in relation to finance. But we can find out if members are content to do that in a moment. Are there any questions on this report? No. Any comments? Okay, can I just confirm then, if members are happy with that suggestion of writing to both parent bodies, partner organisations rather, to confirm that they are happy to help us progress that recommendation that's come out of the internal audit?
Agreed.
Okay, right, thank you everyone. We'll move on then to item 5.4.2, which is the internal audit report on improvement actions, and I'll ask again the Chief Internal Auditor to speak to this report.
Thank you, Chair. This audit was scoped in detail to provide assurance to the Audit and Performance Committee on the arrangements on the framework for the management of performance on the improvement plan. Consideration was given to processes for collation, scrutiny, challenge, consistency of reporting, information presentation, and also the supporting evidence which sits behind the content within the plan. Substantial assurance has been taken from these arrangements, meaning that a sound system of governance, risk management and control exists. There are two actions for follow-up within the action plan, but on the whole, I would say that this is a strong report. I'm happy to take any comments or questions, but obviously this follows on from a paper that we've already considered at this committee.
Okay, thank you very much. Can I ask members if they have any questions on this report? Any comments? Okay. No, as you say, a very positive outcome of that report on the improvement action. So thank you for that. And then the final internal audit report that we have is 5.4.3, which is on the provider sustainability payments. So again, I'll ask the Chief Internal Auditor to speak to that. Thank you.
Thank you, Chair. This is the report on the audit of provider sustainability payments. The partnership has, as a response to the pandemic, responded at pace to establish processes and procedures to provide payments as required to ensure that social care providers were able to sustain their services throughout the pandemic. The scope was to provide assurance over these arrangements in place and to ensure that the payments were made as appropriate. Reasonable assurance can be placed on these arrangements, which means that generally sound systems of governance, risk management and control are in place. There are 4 actions which are included in the action plan, 3 of which are of low risk and 1 of medium importance, which relates to a single duplicate payment, which was identified in our sample. Areas covered by this audit have reference to systems which are in use by the Perth and Kinross Council, and as such, this report will be presented in the future to Perth and Kinross Council's Audit Committee for their consideration also. The arrangements that were put in place, as I say, were put in place at pace, and whilst the particular officers were also supporting other areas of delivery of essential services. So I really think that needs to be taken into consideration when the committee is considering this report, because whilst it has a reasonable assurance, it was under these arrangements were put in place under quite extensive pressures within the service. But I'm happy to take any comments or questions on this paper.
Okay, thank you for that. Are there any questions on this paper? No, and the only question that I asked, I think again in the pre-agenda meeting that we had, and I don't know whether we were able to find an answer to it. It was in relation to the second action point about the general cap of 25% that should be in place on the annual contract value, and a control not being in place. It was just wondering whether we knew if that had been exceeded or not in the absence of the control.
It would, from my auditor's perspective, it was very difficult to actually ascertain one way or the other without a control being in place. So she wasn't able to establish that. I'm not sure whether any member of the partnership staff were able to establish that.
Okay, I don't know if anyone else wants to pick that up.
If I could come in, Chair, it would be wrong for me to provide categoric assurance. I can provide a level of assurance that we didn't exceed the cap, but I would need to formally double check that and provide written confirmation out to yourself or to the wider committee.
Okay, thank you. And I think we all do understand, and I hope I speak for all members of the committee, that certainly in relation to things like that, where we as a health and social care partnership, and indeed across all areas of the public and private sector, we're having to adapt very quickly to the situation. That you know, it's very welcome that these are relatively minor recommendations, but important nonetheless that they have been put forward to us. So thank you for that. Are there any further comments that people wanted to make? No? Okay, right. Well, thank you for those reports. They were very welcome and useful to give us an idea of where we're at in certain areas. So if we move on now to item 5.5, which is the annual report for internal audit for 2020-2021. So back again to the Chief Internal Auditor.
Thank you, Chair. The public sector internal auditing standards requires the Chief Audit Executive to provide an annual opinion concluding on the overall adequacy of the framework for governance, risk management and control. And this report fulfills that requirement. It highlights the role of internal audit, and there's been no restriction within the year to internal audit's independence or objectivity. It highlights internal audit's compliance with the public sector internal auditing standards, where we fully conform. It also highlights that 1.6 what is taken into consideration as part of the suite of arrangements that are in place when arriving at the conclusion and the opinion which is recorded within this report. It highlights the outcome of internal audit work within the year at section 2, along with the follow-up plans, and also the role of the Audit and Performance Committee as those charged with governance. The opinion is at 5.1, and it is that reasonable reliance can be placed on the IJB's risk management, governance and internal controls, subject to the implementation of agreed actions detailed within internal audit reports within the year. I'm happy to take any comments or questions on this report.
Okay, thank you. Any questions first? No. Okay, any comments? Councillor Duff.
Thank you, Convener. It was really just, I suppose, to acknowledge the amount of work that has gone in recently in terms of our internal audit processes, and to welcome the various reports that we've heard about today, and to thank the internal auditor and her team for these reports, which are very welcome, and obviously we'll make every effort to ensure we implement the recommended actions. Thank you.
Okay, thank you, Councillor Duff. Any further comments from anyone? No. Okay, well, thank you again for that report, and it's welcome to see the audit opinion there. Okay, moving on to item 5.6, which is the appointment of the internal auditors for the year 2021-22. And I think the Head of Finance and Corporate Services is going to introduce this report.
Thank you, Chair. This report recommends that Jackie Clark be approved as Chief Internal Auditor, and that we approve that Perth and Kinross Council Internal Audit Services be appointed as the IJB's Chief Internal Auditor 21-22 for a one-year period, working alongside the Tayside Consortium. I would like to also pass on my thanks to Jackie and the internal audit team. It's been an extraordinary year, and we have seen through the year the Audit and Performance Committee the delay in some reports coming forward. But the work that's gone on over the past few weeks to address that has been fantastic, and we've worked well together to bring forward the reports that you see today. And on that basis, now is not the right time to do anything other than extend the current arrangements for a year and look to next year to look at a longer term arrangement. The only other thing that we'll do this year is just look at the timescale set for different reports coming forward and just measure against that, so we can give the assurance to the committee that we're back on track and receiving reports in line with target timescales. So happy to take any questions, but the recommendations are clear.
Okay, thank you for that, Chief Financial Officer. We are being asked to approve the appointment of Jackie Clark as Chief Internal Auditor for this one-year period, and also approve Perth and Kinross Council Internal Audit Service and FTF as the IGB's internal auditors for that same period. Are there any questions on that? Any comments? Okay, on that basis, are we happy to agree to that recommendation?
Agreed.
Okay.
Yes, agreed.
Thank you. Right, and if we move on to the final paper in this section, which is item 5.7, and that's the internal audit strategy and plan for 2021-22, and we're back to the Chief Internal Auditor for this report.
Following on from my appointment for the next year, I can put forward my current plan for you. The public sector internal auditing standards require that the Chief Internal Auditor to prepare a risk-based internal audit plan, setting out planned work for no more than a 12-month period, which takes into account the IJB's objectives, risk and performance management arrangements. Resources for this will be committed by both Perth and Kinross Council internal audit and also by our NHS internal audit colleagues. The strategy is to deliver a risk-based internal audit service by designing the planned activity around the key risks to the IJB achieving its objectives. In arriving at the plan, I've been able to place reliance on the risk management and governance frameworks within the partnership, including the work to arrive at the annual governance statement also. I undertook a mapping exercise to compare internal audit activity with the most recent risk register and highlighted areas where previous coverage had taken place and those which were yet to be reviewed or may have been out of date. Now that enabled me to place assurance on some areas historically and to highlight those areas where there was a scope to undertake a review during this current financial year. As mentioned earlier, the audit of corporate support is to be undertaken this year, along with the two new assignments around leadership capacity and the primary care improvement plan, which are documented within the plan. The indicative scope is captured here, and those will be agreed in greater depth at the commencement of each assignment in order to get the key risks clearly articulated at that particular point in time, and also to be a little bit just aware that services can change over time as well, and priorities may also change. But I'm happy to answer any questions or take any comments on the internal audit strategy and the planned activity for 2021-22.
Okay, thank you for that. Are there any questions? No? Any comments? Okay, well, thank you for that and setting out what the plans are. I think in particular the focus on leadership capacity, given that's something that has been raised a number of times in a number of different fora, is welcome to see what the Internal Audit Service makes of that. So we're asked to approve the Internal Audit Strategy and Plan for 2021-2022. Are we happy to do that?
Agreed. Agreed, Chair.
Okay, thank you for that. Okay, that concludes that section of the agenda. We're now on to the final substantive section, which is the draft annual accounts for 2020-2021. And the first part of that is the paper 6.1, which is the annual governance statement, and I'll ask the Chief Financial Officer to introduce this paper.
Thank you, Chair. The annual accounts regulations require an annual review of governance. This requirement will be met by the approval by the committee of the annual governance statement. The draft annual governance statement before you today concludes that the IJB has in place adequate internal controls. There are a number of areas where further work will strengthen our effectiveness and controls, and these are set out in the action plan for 21-22. All of these are key components of the Partnership Improvement Plan, which you considered earlier on in the agenda. I'm very happy to take questions, but otherwise would ask the committee to approve the annual governance statement for inclusion in the annual accounts.
Thank you. Are there any questions from members on the annual governance statement?
I have a question, Chair.
Mrs. Kilpatrick.
I'm not sure, Jane, where this would be covered, but it's a question really, and we have, I think, had some discussions about it before. In page 152 of 202 pages, it talks about regular review of service quality against recognised professional clinical and care standards is provided by Perth and Kinross Health and Social Care Clinical Governance Forum, which provides assurance to NHS Tayside Clinical Care Governance Committee and to the IJB. So can you explain to me, Jane, what the mechanism is for that?
Chief Financial Officer.
Yes, Pat, I think I'll pass on to Gordon, who'll be able to explain the wider work that's going on. But what we would expect to come forward in terms of annual assurance to the committee in September to support the sign-off of the annual accounts is an annual assurance report. Now, what I would expect is that's made up from assurance from three aspects actually. One which is assurance from our own committee, one which is assurance from the NHS Tayside Clinical Care Governance Committee, who has responsibility for the operational delivery of safe services, and similarly from Perth and Kinross Council in terms of safe delivery of social care services. So the assurances that will come forward, in my view, need to come from all three of those, and that's my expectation in terms of the assurances that the IJB would need in the September committee. But there is work going on to map that out, and I'll pass over to Gordon, who I'm sure will want to just give a high-level overview of that work.
Chief Officer.
Thank you. I recognise the question, and I'm aware of the background to some of the challenges around this and the respective roles of different boards and committees. I think Jane's answer is really helpful in highlighting that the IGB as a strategic commissioning and planning body should be able to be assured in this regard from the statutory partners who have the oversight and responsibility for the maintaining and ensuring professional standards. And of course, it's the case that the Health and Social Care Partnership services are considered routinely in the context of the Clinical and Care Governance Forum, and that allows the Associate Medical Director and the Chief Social Work Officer to take reports to the Care Governance Committee of NHS Tayside, and we should consider whether or not those reports might also go to Perth and Kinross Scrutiny Committee in order to be able to assure the committee, who now have as members the medical and nurse directors. And this is an arrangement that has been put in place more recently because the previous Clinical Quality Forum, where the medical director would have himself, or the nurse director herself, given that direct assurance to the NHS board for their oversight of clinical matters. That Clinical Quality Forum is no longer meeting, so the Associate Medical Director and the Chief Social Work Officer report directly to that committee. Now, that's important in relation to the respective responsibilities for clinical oversight lying with the NHS board and lying with the Associate Medical Director and Medical Nurse Directors. What that doesn't do is necessarily give effect to, I know Pat's view and ambition would be to be cited on some of that information and some of that detail as an IJB member. But as Jane's pointed out, the IJB should seek assurance from the NHS and the Council. What we are doing, though, is looking at the extent to which the work that's underway and is reported to those boards, and in respect of which we have had a high level of commendation, a bit of challenge, and a degree of assurance being expressed, should be considered by the Audit and Performance Committee of the IGB, and whether or not specific reports should come forward to this board. That's the area where we need to bottom this out, because the integration scheme advises quite clearly that it isn't for the IGB to be cited on the level of detail that I think Patrick is looking for as an IGB member to enable her to be assured. The integration scheme says quite clearly, and we've talked about this at a development session and are intending to explore further, that the IGB should be assured by the Chief Officer that there are appropriate arrangements, measures and processes in place to ensure that clinical and professional governance is considered, reviewed and improved upon. That isn't the same as providing the level of detail that perhaps members of the IGB or of this committee might want to see. And we need to reconcile that. We need to reconcile that with the integration scheme. That may require the integration scheme to change. We need to reconcile that with the Getting It Right for Everyone framework that the statutory partners, health and social care partnerships, have signed up to as the model for moving this forward. And we need to probably reconcile that with the arrangements in place in Angus and Dundee, although the integration schemes and the approach taken by Angus and Dundee is different from Perth and Kinross IGB, where Perth and Kinross's IGB's responsibility is focused exclusively on strategic planning and commissioning, and Dundee and Angus have a different role in relation to operational oversight. So it's absolutely complex. It's an issue that we're aware of that needs to be reconciled, and there is an ambition and an opportunity for us to do so in the context both of changes to the arrangements that are being brought forward by NHS Tayside with the removal of the Clinical Quality Forum, and with the opportunity that's presented by the integration scheme. And we have committed to advance those discussions locally and across Tayside, including potentially with further development sessions with IGB members, just to try to bottom out which reports in relation to which matters should land where and who should be assuring whom in relation to these matters, clinical and care governance matters. So apologies, that's a very long-winded answer. It's a very complex area. We're attentive to the ambition of various members of the committee and committed to trying to resolve this so that we can ensure that IGB members are both absolutely clear on where their responsibilities begin and end as members of Perth and Kinross IGB relative to other boards and committees, and are provided with that information that enables them to be assured that they are carrying out their function adequately, appropriately, and in a robust manner. Thank you, Chair.
Okay, thank you, Chief Officer. And I know this has obviously been a long-standing issue, which we've discussed at length, and certainly I think you know my view about. I don't consider a chain of assurance to be assurance. I need to see the outputs and the detail in order to make a fair assessment of whether something is being carried out as it should be. I'm just wondering if you have any indication of timescale for when we might have a resolution to this, because I think Mrs. Kilpatrick makes a very important point that regardless of how we address this deficit in terms of assurance, there is still a gap which we identified as a board quite some time ago, yet still have to progress the agreed mechanism of how we seek and receive that assurance.
So the discussions that are underway will advance that position fairly swiftly, and we should be in a position where we can bring forward proposals to the IGB or involve IGB members in further discussions in the context of a development session. There are reports available that go to NHS Care Governance Committee, and as I've indicated, we need to reflect on the extent to which similar information, slightly different perhaps information, might also go to Perth and Kinross Council's Scrutiny Committee. It is the intention of the Care Governance Committee of NHS Tayside to no longer take those reports as reserved business, so they will become, you know, available in the public domain for members of the public to scrutinise, and potentially for members of the IJB to be assured. But maybe the chair of the Care Governance Committee needs to be engaged in some discussion about the level of assurance that he or she can give to the IJB, as identified in Jane Smith's opening remarks about the level of assurance that the annual governance statement might demand.
Can I come back in here, Chair?
Mrs. Kilpatrick.
Yeah, I sit as the Deputy Chair of the Care Governance Committee, and I see all the reports. And Gordon and Jane have both talked about detail, a lot of detail. The reports, I would say, are very strategically focused, very high level. There is some detail in them, but you know, these reports will be in the public domain. If I'm a member of the public, I can read it. I don't see why they either don't come to the Audit and Performance Committee of the IJB or the IJB itself. And as an IJB member, if I didn't have access to those reports through my role in care governance, I would have no sense or understanding, and therefore would not be fulfilling my governance responsibilities. Because currently there is nothing reported anywhere to the IJB, and I think we cannot put in a report, Chair, that is the case in the line that says, which provides assurance to the Care Governance Committee of NHS Tayside and the IJB. I don't think we can have that in the report. I think we can say that there are steps underway to look at how that might be reported to the IJB, but I don't think we can say in this report, in this governance statement, it's reported to the IJB, because factually it is not reported to the IJB. I would like that minuted.
Thank you. Sorry, Mrs. Kilpatrick. The Chief Financial Officer's request to speak was obscuring my my unmute button. So, Chief Financial Officer, you wants to come in, and then I'll address the point that Mrs. Kilpatrick was raising.
I understand your concerns. What I would say is that this is a draft report that will be form the basis of the final accounts that will be signed off in September. What I would ask is that what my expectation would be is that in advance of signing off the full accounts at that September meeting, that what we'll be bringing forward are exactly those reports that are required to provide the assurance, and they will be part of that will be a form of assurance that's coming from the NHS Tayside Clinical Care Governance Committee. The difficulty we've had up until now is those papers haven't been in the public domain. Bringing them forward, therefore, to our Audit Performance Committee, we've had to navigate that. But you're absolutely right. If we're not able to do that in time for the September meeting, then you would have an issue with the signing off the final accounts. But the annual governance statement is drafted at this stage on the assumption that those assurances can be brought forward in September.
If I could come back to you, I think that's fine, Jane, and I perfectly understand where you're coming from, but I think you need to say that in this draft statement, that this is a draft statement, and that whilst it's not currently reported to the IJB, by the completion of the draft statement or the signing off of the draft statement in September, that might in fact be the case. But I do not think you can say it factually in a draft, even though it's a draft, if it is not true, and currently it is not true. Thank you, Chair.
Yeah, I accept that, and perhaps we should have explained that fully in the covering paper. So if members are content, what I will do is send round almost a point of clarification formally to the covering paper that makes it clear that very specific point, that is on a very clear assumption that further assurance will be brought forward to allow that statement to be accurate. So yeah, I fully accept that part.
Okay, thank you, Chief Financial Officer. That would be helpful, and of course, if we are not at the stage where we have that assurance, which I would hope we would be by September, then we can look at ensuring that the wording properly reflects that position. Okay, can I ask if there are any further questions on the annual governance statement before we move on to the accounts? No? Okay, any comments? Okay, right. Well, we're asked to approve the 2020-2021 annual governance statement for inclusion in the unaudited annual accounts. Are we happy to agree that recommendation with those caveats?
Agreed, Chair. Yeah.
Thank you.
Agreed.
Yep, agreed.
Okay, right, let's move on to the final substantive paper for today, which is item 6.2, which is the unaudited annual accounts for 2020-2021. And I'll ask again the Chief Financial Officer to start introducing this report. Thank you.
Thank you, Chair. I'm very pleased to bring forward today the unaudited annual accounts for 2020-21, which are due to be submitted to the Controller of Audit by the 30th of June 2021. The regulations require an annual review of the effectiveness of the systems of internal control, and that requirement is now met, subject to the caveat around clinical care governance by the approval of the annual governance statement. The annual account includes a management commentary. The purpose of that is to provide users of the financial statements with integrated information on management's view of performance, position and progress. This is set out at page 3 of the account and has been significantly shaped by the impact of the COVID-19 pandemic on service delivery, service performance and indeed financial outturn. The comprehensive income and expenditure statement on page 182 of the papers sets out the £12.74 million surplus, which I referred to in the presentation earlier. On page 183 of the accounts, we set out the £13.9 million of reserves being carried forward to 21-22 again, which I referred to earlier. Significant accounting policies are set out on page 187, along with wider notes to provide explanation of the account. I would note that subsequent to the unaudited accounts being finalised, Audit Scotland nationally queried the accounting treatment of National Services Scotland procured PPE that was utilised by social care during 2021. IGBs, along with NHS boards, are awaiting advice on how this expenditure is to be reflected through both board and potentially through IGB accounts. And once known, the annual accounts will be updated through the audit adjustment process. There is a key meeting of the LASAC, the Local Authority Accounts Advisory Committee, this week, and we hope to have clarity then. We're hopeful that any adjustments that are made through the Health Board accounts and not through the IGB accounts. However, we will need to wait and see the outcome of that meeting. Following consideration of the unaudited annual accounts by the committee, we would be seeking to submit for external audit and make available for public inspection. I'm happy to take any questions.
Okay, thank you very much for that. Are there any questions on the unaudited annual accounts? No. Okay, any comments? Okay, well, thank you for that, and also I'd like to echo the comments that were made by the Chief Financial Officer at the start, thanking Donna Mitchell for her work on this. They're always very clear and easy to read. Councillor Duff, you wanted to make a comment.
Sorry, it was just an observation on page 177 where it lists the voting members. I only see 4 councillors and 3 NHS members there. Is that an omission of some kind? We've got Bob Benson, Pat Kilpatrick, Ronnie Erskine.
It may just have been due to the turnover.
The timing.
Chief Financial Officer, do you have a?
Yes, that is from my recollection, that is just a timing issue pertinent to that particular date. But I can doubly clarify that, Councillor Duff, and just confirm that to you.
I see the statement above it at the 31st of March. It may well just have been a timing issue. Yeah. I'll leave it with you. Just an observation. Thank you.
Okay, thank you for that. Well, in the absence of any other questions or comments, we're asked to authorise the Head of Finance and Corporate Services to sign the unaudited annual accounts on behalf of the IGB. Are we happy to agree to that?
Yep, agreed.
Agreed, Chair.
Okay, and then we have, just for your information, items 7.1, which is the Audit and Performance Committee work plan for the current year, and then also item 7.2, which is the record of attendance. Are there any questions or comments on either of those two, or can we note them? Oh, okay, right. That's the public section of the meeting concluded. I'll just say that the next meeting is on the 2nd of August, currently scheduled at 10:30 AM. So thank you everyone for your attendance.